Bismillahirrahmanirrahim. Okay, we'll start with it. Anyway, we'll start anyway. Let's see. So far we discussed about we discussed about structures of glomeruli, and we discussed about complement, and we also discussed about hypersensitivity reactions. Okay, so with this basics we are going to see about the glomerular diseases. So normally the glomerular diseases, usually the glomerular diseases are classified into primary and secondary, and another one is hereditary. So primary means there is problem in the glomeruli, okay, problem in the glomeruli which producing the glomerular disease. And secondary means there is some systemic disease which is damaging the glomeruli which produces the glomerular disease. It is due to some systemic diseases. Hereditary, actually there is some genetic mutation happens, for example Alport syndrome. Okay, there are many hereditary diseases. Okay, because the thin membrane disease, in some of the individuals the membrane will be very thin. Okay, in those people from the day one of the born there will be hematuria because the membrane is thin and the porosity is increased, even the blood keeps on leaking. Okay, so these are the various diseases we see in the hereditary conditions, but for us it is more important is primary and secondary glomerular diseases. Okay, but if you see the clinicians, okay, because we have to relate what we are studying with the clinical findings. So clinicians mostly they look into a lab investigation and they try to classify it. So first of all they see whether the glomerular diseases is producing proteinuria or hematuria. Okay, if the proteinuria is asymptomatic, which means there is proteinuria, but it can be symptomatic or asymptomatic. Here if it is asymptomatic, which means there is no edema. Easily visible clinical sign is edema, periorbital edema and facial edema or anasarca. Because there is proteinuria, you all know, because we discussed about the pathogenesis, right? Yes. So if there is proteinuria, normally there will be edema. So actually usually there will be edema, and this if the person is not having any other signs, it is, or the patient is not complaining of anything, so it is called asymptomatic proteinuria. This proteinuria usually they identify it without edema. Okay, so another thing is, if it is symptomatic, then we call it is nephrotic syndrome. It's called nephrotic syndrome. So then they will produce all kind of symptoms. What are the symptoms they produce? So what are the symptoms they produce? Yeah. So they may have frequent infections. They may have developed coronary artery disease. Okay, these are the late complication of nephrotic syndrome. And if it is the early period, they will produce edema, and then they produce dyslipidemia, then they may produce lipiduria. Okay, during the loss there is a special protein called transferrin loss happens. This transferrin is a protein involved in iron transport. Okay, so if transferrin is lost, automatically they will lead to iron deficiency anemia. They will lead to iron deficiency anemia. That leads to iron deficiency. Actually, that is my problem. Actually, whenever I discuss some new things, I remember. Okay, So it is called iron deficiency anemia. I think I didn't discuss with, I think even to females I didn't discuss. Very important. Because the transferrin is lost even in the long term. It actually should come here. Even in the long term nephrotic syndrome, there is a loss of transferrin like complement. So that also lost, transferrin is lost, that leads to iron deficiency anemia. Okay. So now there is a edema, dyslipidemia, lipiduria. Okay. Understand? Okay. Apart from anything we missed, so there will be coexisting hypertension. Okay. So because of the alteration in the circulation. So any other thing we missed? I think most of the things we covered. So these are the things we see in the nephrotic syndrome. So if we have these things, symptoms and signs, then we call it as a nephrotic syndrome. And most important criteria is 3.5 grams per day loss of that's it. Do you understand? I'm going fast. Okay. So you know, brother, if there is symptomatic proteinuria, then we call it as a nephrotic syndrome. Okay. Symptomatic. See, the proteinuria, understand, the proteinuria is there. If it produce symptom, it is called symptomatic proteinuria. If it doesn't produce symptom, it is called asymptomatic proteinuria. So when it is symptomatic, the first criteria is we see how much loss. If it is more than 3.5 grams per day, it comes under nephrotic syndrome. So what are the symptoms can give? In a long-term nephrotic syndrome, there is loss of complement. Along with the protein, there is loss of complement. So that leads to infections. That leads to infections. And what happens is there is dyslipidemia happens. You know, what happens in nephrotic syndrome? The liver starts producing lipoproteins. Lipoproteins leads to dyslipidemia because increase LDL and decrease in HDL happens. That is thrombogenic. Okay, that is actually arthrogenic. Arthrogenic means it is tendency to form atheroma. Tendency to form atheroma in the coronary artery. So it is called coronary artery diseases. It's called coronary artery disease. It is very dangerous one because it produces infarction, myocardial infarction. Okay. So then you all know why the edema happens, because of proteinuria. Because of proteinuria, they go for hypoalbuminemia. That leads to the so that leads to edema. Why? Because colloidal osmotic pressure is reduced, so they cannot get back the fluid, so automatically the edema forms. Okay, so edema can be seen and dyslipidemia can be seen because of the more lipoprotein that is excreted in the urine. That is called lipiduria. So one extra thing I am telling today is there is loss of transferrin. That can lead to iron deficiency anemia. And because of circulatory change, there will lead to hypertension. Okay, so these are the things you can see in the nephrotic syndrome. Okay. Now there is mild proteinuria. Okay, not like nephrotic range. There is mild proteinuria, but along with hematuria. Please remember that proteinuria is not like nephrotic. There is very, very mild proteinuria. Traces of protein can be seen, but there will be hematuria. So this is, if it is not producing any symptoms, then it is asymptomatic hematuria. Okay, why I am telling is, even in hematuria there may be mild traces of protein. Okay, now if it produce symptoms, okay, it is called nephritic syndrome. Nephritic syndrome. So nephritic syndrome, when we say, it is always acute. So nephritic syndrome means there is severe loss of proteinuria. Okay, there is severe loss of hematuria. Along with loss of hematuria, increased hematuria along with severe hypertension, and there will be coexisting azotemia. Azotemia means increased in urea, nitrogen, or creatinine. Understand? Increase in urea and creatinine, and that will not produce any symptoms. If it produces symptoms, it is called uremia. If it produces symptoms, it is called uremia. Understand? If it produces symptoms, it is called uremia. Why it's not showing there? Okay, it is called uremia, right? Yeah. HDL and increase in LDL, decrease in HDL, which happens in the nephrotic syndrome. Hypertension. So, okay, so this is all happens in nephritic syndrome. So what you have to understand is, when it becomes uremic, the nitrogenous waste products and creatinine all goes and deposits in many organs. It deposits in gastrointestinal tract. It will produce serious abdominal pain, very acute abdominal pain. It can deposits in the pericardium. It will affect the diastole and systole of the heart. Okay, it will produce restrictive pericarditis. The heart cannot function normally. It can deposit in the lung and the pleura. It will produce difficulty in breathing. Okay, so it deposits in many organs. It produces different symptoms, but actually if it starts depositing in the pericardium, then cardiac function is compromised and the patient dies. Okay, so you all understand this. This is about azotemia and uremia. Okay, so in the nephritic syndrome, if there is severe hematuria, and that leads to serious hypertension, and then it is all happening because the glomerular filtration is not happening. Okay, if there is complete fall of GFR, okay, then it is called, and increase in serum creatinine. Understand? It is called rapidly progressive nephritic syndrome. Rapidly progressive glomerular nephritis. Understand? So this is RPGN, or rapidly progressive glomerular nephritis. This is very, very dangerous. If you are not intervening, the patient even die within few weeks. Okay, because of the complete renal failure. Okay, so this is about then if you leave the disease, okay, like that, they will go for chronic glomerulonephritis. Then all the kidney goes for fibrosis. Then they go for end stage renal disease. You all understand this? Okay, I will repeat once again. Then we will go in depth of the pathology.
Has the uremia cause nitric oxide deposition in the lung? This cause hypoxia?
Yeah, I will come to that. Okay. Actually, Asil, in the acute renal failure, we will discuss more about that. Okay, because we should know about tubular function. Okay, tubular processing. Okay, in that we will discuss more about that. Okay, if I tell now, other concepts will get confused. Okay, so now, because in acute renal failure, we will be talking more about azotemia and uremia, and along with other issues. Acute renal failure confuses with acute glomerular nephritis. That is a critical differential diagnosis. Okay, acute tubular injury and acute glomerular nephritis. Okay, now we are discussing. What we are discussing is, we are seeing the lab investigation. Okay, and we are relating the what changes happening in it. Understand? one of the lab investigation which is a criteria for everything is proteinuria and hematuria, right? That is the center point, okay, which classifies the disease, okay. So one is proteinuria, other one is hematuria. Okay, proteinuria may be asymptomatic, right? Asymptomatic, or it may be symptomatic. If it is symptomatic, it is called nephrotic, which means the proteinuria is more than 3.5 grams per day, okay. And if it is asymptomatic, it must be less than 3.5 grams per day. If it is 3.5 grams per day, which means there is serious fall of albumin in the blood, okay, albumin is fall, then automatically they will produce edema. Then the liver produces abnormal proteins, dyslipidemia. Then this leads to lipiduria, okay. Then this leads to atherogenesis, okay, coronary artery diseases, and complement loss happens. Then complement loss will lead to infections, especially pneumococcal infections, and transferrin loss leads to iron deficiency anemia. So these are the signs and symptoms can happen in the nephrotic syndrome, okay. Now if there is hematuria and there will be coexisting mild proteinuria, very mild proteinuria, that can cause, okay, if it is asymptomatic, okay, which is the early signs of nephritic diseases. Early signs of nephritic diseases immediately you have to identify, okay. If it is symptomatic, it is nephritic syndrome. It is nephritic syndrome. So symptomatic means what we mean, the patient will have severe hypertension, okay, that will give lot of headache, okay, the patient will have serious headache and the patient will suddenly collapse, okay. So that is the characteristic clinical presentation of acute nephritic syndrome. The patient will say that intolerable headache and they will collapse, okay. So that is the most commonest presentation of nephritic syndrome, whereas nephrotic syndrome will not come like such emergency. The patient will not come like emergency. Usually the mother or somebody say that there is a edema in your face and pediatric edema, that is how they will enter into the clinics. In acute nephritic syndrome, they will always come with sudden fall or sudden headache. So that is not going in analgesic, okay, and they will hear the palpitation, all the acute symptoms will be there, they will come, okay. When they come, that is a symptom and we evaluate it, that is the hypertension will be there, that will be high grade hypertension. And if you see the serum creatinine, okay, if GFR is less, in that case then serum creatinine will be more, okay. If GFR is less, serum creatinine will be more. If GFR is maintained, okay, then creatinine will not be there. So it is called as nephritic syndrome, but without compromising the GFR, without compromising the GFR. So if the GFR is compromised severely, the serum creatinine is increased rapidly, then it is progressing, called rapidly progressing glomerular nephritis. Rapidly progressing glomerular nephritis. And if the patient is coming with rapidly progressive glomerular nephritis, prognosis is very bad. Prognosis is very bad because we need time to control the disease, okay. So rapidly progressing, no, it will fraction of second it keep on spoiling all the glomeruli, okay. Within 3-4 days complete glomeruli is damaged. Only thing we can try to save the patient by keeping them in dialysis, all this stuff, but the kidney will be gone. If they are not coming to the hospital, it's difficult to save the patient, okay. So this is the point you should understand. So they will come with acute nephritic and you have to check the serum creatinine. If it is not too high, GFR is normal, then we need not to worry, just we have to control the disease. If the GFR is down and serum creatinine is high and it is only azotemia, if they have started producing symptoms related to the azotemia like chest pain, like abdominal pain, and pain during breathing, all it's or joint pain, okay, all will leads to that uremic syndrome. It is a definite case of rapidly progressive and glomerulonephritis. Okay, so like that you have to analyze it. Then if you recover this patient, the glomeruli will recover. Okay, if it is RPGN, okay, if the crescent is formed, okay, that inshallah I will explain in the slide. So if some more damage is happened, that even though if they recover, they go for glomerulosclerosis, they go for glomerulosclerosis, that will end up with chronic glomerulonephritis. Okay, and then if more glomeruli, 50% of the glomeruli are gone and 50% of the tubules are gone, 50% of the interstitium is gone, then it is called end stage renal disease. End stage renal disease. Okay, so after 50%, the patient needs to survive on dialysis. Okay, anything less than 50%, the patient may survive for some period of time. Okay, so without with that same treatment. Okay, otherwise the patient has to go for dialysis, frequent dialysis, or the permanent solution is transplant treatment. Okay, so all understand this. So with this background, we will go to the nephritic syndrome. Again, I'm going to give some more clues to diagnose nephrotic syndrome. So you all know this is the basement membrane. Okay, now this basement membrane, inside we have a endothelial cells, right? Okay, then this is the other side of the basement blood vessels, other side basement membrane, and we also have endothelial cells. We also have endothelial cells. Then we have mesangium here, right? This is the mesangium. Okay. Now we have endothelial cells here. So this is the nucleus of the endothelial cells. Okay, what we are see here is porocyte. Okay, they are the porocyte, and we have nephrin. That area is called slit diaphragm. Okay, see, any change happens in the basement membrane. Okay, I'll do this color. So any change happens in the basement membrane. Okay, structural change, understand? The basement membrane become thick or they become normal, but cationic capacity comes, or there is loss of porocyte process, or there is loss of porocyte, or some change happens in the mesangium. Okay, this all can lead to nephrotic syndrome. Nephrotic syndrome. You will not see inflammation. You will never see intense inflammation in nephrotic syndrome. Okay, whether it is primary nephrotic syndrome or secondary nephrotic syndrome, you will not see serious inflammation, intense inflammation. Okay, if there is structural change along with inflammation, that will be nephrotic nephritic syndrome. Nephrotic nephritic syndrome. Okay, and if there is inflammation, whether it is mild or moderate or severe, and there is proliferation mild or moderate or severe, that will end up with hematuria, that will leads to nephritic syndrome, that leads to nephritic syndrome. So if you say nephrotic syndrome, all the pathology will be related to structural changes. Structural change, maybe some change happening at the molecular level, or some change happening at the electrical gradient of the basement membrane, or there may be some changes, loss of cells may be happening, but whatever it may be, you will never see inflammation. If you see inflammation, keep in your mind it is nephritic. It will have hematuria. Okay. Now
When you can say that nephrotic syndrome?
that I will come. There are two diseases I will discuss: nephrotic and nephritis. Okay. So there are many diseases. Just I will discuss two diseases. Okay. Now let us see certain examples. See, I told, right, Remember the filtering area in order. Okay, so you need not to memorize anything. So anything you memorize, if you are going in order, you will never memorize. One thing, if you remember, next thing it follows. Okay, so it is basement membrane, above endothelium, below we have, so I put little bit basement membrane thick. Okay, this is normal thickness of the basement membrane, and I put the photocyte process. Okay, before going into that, in a light microscopy we see this. Okay, and we will not see the podocyte process. Food process we cannot see in the light. Normally, even in normal glomeruli, we cannot see, even in 100 magnification, you cannot see the podocyte food process. You can see podocyte. You cannot see the podocyte food process. Okay, so basement membrane we can see, and endothelial cells we can see. Mesangial cells we can see, but we cannot see the podocyte food process. Okay. So there is a disease that leads to loss of food process. That leads to loss of food process. Okay, the podocyte will survive. That is, only loss of food process happens. That will produce massive proteinuria. Understand? So usually this is seen in the children. This is seen in the children. Okay, now that is called, that cannot be detected in light microscopy, and in immunofluorescent is used to detect the immune complexes. So here there is no immune complex, so there is no immune complex detection in the immunofluorescent. Only in the electron microscopy you can see the effacement, loss of podocyte food processes. Then we call this as a minimal change disease. See, now the filtration is happening, right? Okay, now we have Bowman's capsule, then it becomes a tubule, right? It becomes a tubule. This is all tubular epithelial cells. Tubular epithelial cells has brush border. We have especially proximal convoluted tubule epithelial cells has brush border. Okay, so what happens is, when there is massive proteinuria happening for a longer duration, you know the liver secretes lipoprotein that also get excreted in the urine. Now we get lipid. Okay, then this lipid is absorbed by the proximal convoluted tubular epithelial cell, and you can see fat vacuoles. So that's why in the beginning of the development of this pathogenesis and all, first they saw only the morphology. Okay, and they saw that lot of fat in the tubular epithelium, that they thought it is maybe some fat disease. Okay, some fat problem, so lipid metabolism problem, they thought some may be related to that, so they gave the name lipoid nephrosis. Understand? They gave the name lipoid nephrosis. Okay, but nowadays we are not using that name because we know the exact pathogenesis. Okay, it is due to the effacement of the food process. But in any nephrotic syndrome, long-standing nephrotic syndrome, you can see this kind of vacuoles in the proximal convoluted tubules. Okay, it is called lipoid nephrosis. Understand? Okay, this is one disease called minimal change disease. Okay, in some disease, okay, let us draw the glomeruli. Okay, we'll draw a glomeruli. See, what is this? Bowman's capsule, and I'm going to draw the capillary. Okay, this is the capillary. Okay, and this is the mesangium. This is the mesangium. This is all the mesangium. Okay, this is the mesangial cells. Okay, Now, in between this capillary tuft, 2-3 capillary tuft, you see two mesangial cells, 2 to 3 mesangial cells. In case in mesangial cell, it is mesangial hypercellularity. Mesangial hypercellularity. Okay, now, right? Now you all know endothelium is lined by the, sorry, capillaries are lined by endothelial cells. It has a thick basement membrane, and they are also lined by the endothelial cells. Okay. Okay. Now this is a capillary and endothelial cells. This is capillary and endothelial cells. And you have porocyte. Okay, porocyte food process. Okay. So, and you have here parietal epithelial cells. Parietal epithelial cells. Okay. Now, what happens is in some person morphologically, some part of the tuft is sclerosed. Some part of the tuft is sclerosed. Okay. So first, before seeing the light microscopy, they thought it is some sclerosis happening. Okay, they don't know why it is happening. They don't know why it is happening, and now it is completely sclerosed. But not all the tuft. Only some part of the tuft is sclerosed. So it is a segment of the glomerular capillaries is sclerosed. Okay, so it is segmental. It is segmental sclerosis, but sclerosis is happening in the glomeruli. It is segmental glomerulosclerosis. Another beauty what they noticed is, see, for example, this is the kidney of that individual having massive proteinuria, okay, and they took a biopsy. They took a biopsy, and in that biopsy, they are seeing lot of glomeruli. Understand? And this is the area corticomedullary area. This is the area corticomedullary area. This is the area cortex. Understand? Okay. And they are noticing there are some tuft in the glomeruli near to the corticomedullary area showing sclerosis. Even in the glomeruli, only some area is showing sclerosis. Understand? But rest of the glomeruli looks normal. Okay, so they are normal. Here they are showing sclerosis. Understand? So it's not all the glomeruli showing the disease, only few glomeruli are showing the disease. So it is focal disease, it is not diffuse disease. Diffuse means it should present in all the glomeruli. So only focal area is showing the disease, and if you see that focal area, the affected glomeruli is this one. I draw it big. The affected glomeruli, only a few area of the affected glomeruli, few capillaries of the affected glomeruli is showing the disease. So it is a focal. Okay, focal came from here. Focal, understand, came from here, and segmental came from here, and it is a glomerulosclerosis. So it is a focal FSGS, focal glomerulosclerosis, segmental glomerulosclerosis, because there is a disease called diffuse segmental glomerulosclerosis. And if all the capillaries are sclerosed, if all the capillaries are sclerosed, it is called global sclerosis. It is called global sclerosis. If all the glomeruli are sclerosed, okay, it's a diffuse global glomerulosclerosis. It is diffuse global glomerulosclerosis that can be seen in diabetic nephropathy. Most commonly seen in diabetic nephropathy. Okay, so this FSGS is maybe seen in many hereditary conditions. I don't want to go in detail of it. More molecular genetics. So FSGS seen in children is suspect hereditary condition. The problem in this FSGS is, see, now you are seeing a biopsy, you are seeing glomeruli, right? You are seeing glomeruli. Why they took the biopsy? Because of because of proteinuria, because of massive proteinuria, and they took the biopsy. So this is the biopsy that they took, and you are seeing lot of glomeruli, right? So in the glomeruli, you are seeing some of the glomeruli is showing sclerosis. That too, in that affected glomeruli, some part of the capillary is showing sclerosis. Understand? Okay. If this glomeruli comes out in the biopsy, it's good. Okay. It's the same case. Now they take a biopsy. They took the biopsy because it is a focal disease, right? In all the focal disease of kidney, this is the problem. If the biopsy is not having that focal part, okay, so what I will do, I don't have electron microscopy. Understand? I'm also not see, all the lab will not have electron microscopy. If you see electron microscopy in Jeddah, there will be one electron microscopy. That too will be in the government hand. Understand? In India, private hospital is having electron microscopies only two. Understand? So it is not even in America it's like that. So it's mostly the university hospitals will have the electron microscopy. Okay. So what we are seeing is, now they took a biopsy. The glomeruli all looks normal, but there is massive proteinuria. Okay. What I will diagnose? I will diagnose it as minimal change disease. I will diagnose it as minimal change disease, because light microscopy looks normal, but there is proteinuria. I have to say something, so I said minimal change disease. Understand? So they give steroid immediately, because minimal change disease do well with steroid therapy. Understand? So after that, usually the minimal change disease goes off. Okay. It will be controlled. What happens after steroid therapy? Also there is massive proteinuria. It is not stopping. Understand? So then they may take biopsy in another site. If that may show the focal segmental glomerulosclerosis. You understand? That may show the focal segmental glomerulosclerosis. So immediately that biopsy comes, then I will change. Usually nephrologist, if he is any budding nephrologist, he will immediately ask what Dr. Suban you gave, last biopsy you gave in CD, minimal change disease. This biopsy you are giving FSGS. What you are thinking? Okay. So then if he is a budding pathologist, we budding nephrologist, usually we make him to understand. Okay. So then you will understand. Usually the senior person, they will understand. Okay. So now only the disease came to them. Okay. Now in the disease area, the focal area represented the biopsy. Okay. So this is our diagnostic issues. So now you all understand the concept. Why I am telling this story is to understand the focal segmental part. That's why I am telling this story. Okay. Focal means some part of the glomeruli is affected. In that affected glomeruli, some part of the glomerular tuft is affected, that is segmental. Okay. So focal segmental glomerulosclerosis, or other than a renal transplant pathologist, why it is important is, for a general physician, for the future residents like you, why it is important is, focal segmental sclerosis primary is not, you will never see in your life. If you come to this field, you will see. Otherwise, you will not see in your life. So most commonly you see FSGS in a HIV patient, FSGS in an obesity patient, FSGS in a dyslipidemia patient, or the person donated the kidney, living with one kidney, that patient. Okay, so in those individuals you will be seeing, or any drug reaction, okay, or family donate reaction, or the person is taking some drugs. So these are all the things you should keep in your mind. Okay, so what is the reason for uh, so focal segmental glomerulosclerosis in adult? Understand? Maybe some cancer related problems. Understand? So like same thing, what comes from membranous glomerulopathy, we have to think for this also. Understand? So we have to evaluate the case in and out to come to a conclusion. We have to solve that problem, otherwise this will not be solved. Okay, otherwise this will not be solved. So this is again structural alteration. Again structural alteration. If you see in electron microscopy, if alhamdulillah you have electron microscopy, if you see in electron microscopy, you see there is some injury to the porocyte. There is some injury to the porocyte. It may be nephrin lost, it may be slit diaphragm lost, or it may be food process lost. So some injury, there will be surviving porocyte, long-standing FSGS, podocyte slowly disappears. Podocyte slowly disappears. Understand? So this is about FSGS. You all understood about FSGS. See, immediately you have to compare MCD and FSGS. Okay. So when you are studying, most of the time compare and study, you will never forget. Okay. If you are studying alone, then you will forget. Okay. So compare the features and if you study, automatically your brain will never forget. Inshallah. So now let us discuss about another disease. I am going to discuss about the systemic related nephrotic syndrome causing disease. Okay, so first I will take diabetic nephropathy. Diabetic nephropathy. See, in diabetic, okay, in the class I couldn't able to discuss much. So diabetic is very dangerous one. See, in diabetic, what happens is, inshallah in the endocrine module we will discuss more. In diabetic nephropathy, what happens is, now you just remember there is a product called AGE. Okay, this is called advanced G is for glycosylated. I didn't give in the notes. Glycosylated end products. Okay, advanced glycosylated end product. Normally we call age. So advanced glycosylated end products. This product is increased in their blood. In diabetic patient, these products are increased in their blood. Automatically, see, our glomerular is like a basket. All comes there and put the things here. So automatically they deposit in the basement membrane. They increase the thickness of the basement membrane. Dangerous thing they do is they change the anionic capacity of the basement membrane. Okay, so first they start with just depositing. That deposit is enough to cause proteinuria. So that's why they call it as a microalbuminuria. So just age comes and deposits, that leads to microalbuminuria, and then the basement membrane reacts and more basement membrane is formed. Okay, that leads to massive proteinuria. Yeah, then it will become non-selective proteinuria in the long standing. Okay, and it also increase the thickness of the mesangium. Okay, so now one side you see basement membrane is thickening, mesangium is thickening. This whole compress the capillary. Capillary will be narrowed down. Understand? Then automatically glomerular will not get the enough blood supply. It is go for slowly ischemic change and they will go for fibrosis. Understand? So completely glomerular fibrosis happens. Understand? So let me draw this, because in the video I think you will not understand. Okay. See, let us take this capillary, glomeruli. What is this? It is a glomerular capillary. Just I am putting the end so that you can understand. This is the capillary. This is the mesangium. And we all know the mesangium contains mesangial cells. They have mesangial cells, and the capillaries are lined by endothelial cells. They are lined by endothelial cells. Now here we have podocyte. Okay, podocyte. Right. Now what happens in diabetic? You all know there is a product called AGE that comes and sits on the basement membrane. They first starts with microalbuminuria. It is called microalbuminuria. So that's why, but they have frequent urination. Okay, Polyuria is doesn't, and don't mix up both things. Polyuria happens. Okay, now this is the blood vessel, right? In diabetic patient, what is the problem? Insulin cannot do their function properly. Blood glucose level is increased. Okay, see, blood glucose level means there is some component in the blood is increasing, right? So automatically here more particles are increasing, that will suck the fluid from the cells. That will suck the fluid from the cells. For example, if you take uh, water, understand? Okay, you know osmosis, brothers? And okay, now you are taking water, right? Okay, this is just a membrane, and you are putting salt here. You are putting salt, sodium chloride. Automatically the water comes here. Automatically the water comes here. Same thing happens here. Instead of salt, you have glucose. Okay, for example, if you take a cucumber, you know the cucumber? Cucumber, pickle, cucumber. Cucumber. Just to take a cucumber, put it in a full of salt water. What happens? The cucumber loses all the water, right? It becomes small. Even if you put it in the sugar water, same thing happens. Even if, because we don't like sweet, but so that's why we are not putting in the sugar. Actually, if you put the same cucumber and in the sugar water, then all the water comes out. Understand? Because outside the solutes are more, so all the water comes out. Same thing. So we have glucose in the blood. Then when the cells see it, it sucks all the water from the cells. So blood volume is increased. So immediately we have to reduce the blood volume, right? So immediately it is filtered more. It is filtered more. So automatically we get more urine. We get more urine. Understand? So once the more urine goes, then automatically we get reduced blood volume. That is sensed by the hypothalamus. Immediately that gives the thirst feeling. Okay, that's why diabetic patient always feel thirsty. Okay, and protein is getting lost, right? Because of the age products deposition, protein is getting lost. That's why they feel hungry always. Understand? They eat more. Even though they eat more, loss of protein, then protein from the muscle all get lost. Okay, so they will even eat more, they will be very thin. Understand? So this is the problem in the diabetic. So now coming to the point here, now the age products are coming, right? So why I told this is because you should not get confused with polyuria. Mechanism for polyuria is different. Okay, here the mechanism of albuminuria is different. Here because of the advanced glycosylated end product deposition. Okay, slowly that product deposition increases, then the basement membrane thickness happens. The basement membrane thickness happens. Now the basement membrane is thickening, right? Meanwhile, the mesangium also reacts. The mesangial cells produce more mesangium in diabetic patient. So the mesangium also thick. Understand, brothers? Yes. So now you just to think you are standing here. Okay. For example, Abdul Rahman is here. Okay, so what happens now? All are compressing, like you are got up in a mina stampede. Understand? So it is all the people are compressing, right? Same thing happens here, like mesangium, all the connective tissue compress, and the lumen narrows down. The lumen narrow down, it becomes ischemic glomeruli. It becomes ischemic glomeruli. Slowly they go for complete fibrosis. They slowly go for complete fibrosis. They start with basement membrane thickening, then mesangial widening, thickening happens, then they form nodules of collection of connective tissues, then the whole collapse happens. Okay, whole thing will be collapse. So that nodules are called Kymel-Still-Wilson nodules. Kymel-Still-Wilson nodules, very famous MCQs in the most of the exams. Kymel-Still-Wilson nodule, definitely I will not ask that. So Kymel-Still-Wilson nodules, understand? Okay, so you all understand, brother? So that's why diabetic patient, insulin dependent this is proven study. Insulin dependent there are two types of diabetics. One is insulin dependent, other one is non-insulin dependent. So insulin dependent diabetes pill test patient, usually it will be detected in the child age. Okay, so it is due to some hereditary issues. The insulin dependent diabetic patient, if they are not taken proper care, automatically within 8 years complete renal failure happens. Complete diabetic nephropathy spoils the complete glomeruli. All the glomeruli become fibrotic. All the millions of glomeruli become fibrotic. Okay. So if it is non-insulin dependent diabetic mellitus, it will take time, 10 to 15 years. 10 to 15 years. There is no any accurate date we can say. But for insulin dependent diabetic mellitus, people studied extensively. It is 8 years. Okay. So if that's why diabetic people has to take care of the glucose level. We cannot avoid this happening. Only thing we can progress it. We can progress it. Okay. Now this is about structural changes happening in the systemic disease. Structural changes happening in the systemic disease. I'll share one more systemic disease. You know amyloid. Okay. Amyloid is abnormal protein, abnormal structured protein. See, if the person is having tuberculosis, if the person is having tuberculosis, okay, I'm drawing lung like a kidney, okay, okay. So now the person is having tuberculosis. Let's check your respiratory module knowledge. Okay, what is this? Primary, secondary, or tertiary? What type of tuberculosis it is?
No, tertiary is systemic. Primary.
Why it is primary? What it is called as? Subpleural nodule. Up, lower part of the upper lobe, upper part of the lower lobe. Yes. Okay, and near to the pleura, subpleural nodule. Then after 3 weeks, it enters the node and it goes to the corresponding hilar node. When you see only subpleural nodule, it is called gone focus. Along with hilar node, it is called gone complex. If it is calcified, if it is fibrous, if you seen in the X-ray, it is called Ranke's complex. Okay. Okay, you should relate any, so otherwise you will not. So inshallah, if they would have allowed me to take, you would have never forget it, because I would have asked question about CRS module in the CVS. Okay, so you will never forget. So if they allowed me to ask, about GU1, I would have asked question from GAT, GU1, all integrated. We would have asked question in the GU1. Okay, okay. So that's how you have to grow. Understand? Stepwise, slowly going and facing the license exams. Okay, so you will never feel any hard in it when you face the license exam. Okay, every time when you cross certain step, you have to face the hardship. Life is not interesting.
After the whole exams, make one exams, integration between 3 years.
Yeah, that's a good idea. That is the idea actually which I told, but actually any ministry had a policy that I told to keep only one exam. Okay, there is no need of n block.
Yeah.
Keep only one exam, at least 3 exams. Okay, and actually it is like same portion we are having 2 times. See, if we have, for example, in the courses, mid-semester portion syllabus is different from the end semester portion, right? So that is the meaning. There is some sense in having 2 exams, but you have the same syllabus for end block as well as for the end semester. So soon, inshallah, you can see the change, inshallah. So we may keep, but we'll try to integrate the questions. No, actually, you have to clear at once stretch the license exam with a good score. So which means you have to be trained for that. Okay, now coming to the point. So now, see, you have here. This is a primary tuberculosis. Understand? So this is the primary tuberculosis. Okay. So then the patient immunity is good. Okay, it is controlled. Understand? Then the patient immunity after 20 years falling down. Then it goes to the apex and it forms the severe lesion and it forms a cavity. It forms a cavity and it will be stay for longer period, and the person, what happens is, because of lot of cytokines and other chemical substances produced by the inflammatory cells, the liver will become super reactive. Okay, they will keep on synthesizing 3 proteins. One is serum amyloid A, other one is CRP, other one is fibrinogen. Okay, serum amyloid A is the amyloid abnormal protein. Okay, so what happens is it gets collected in the kidney. Okay, it goes to the glomeruli, it get collected and it get deposit in the basement membrane and the mesangium, and it will construct the glomeruli. Okay, so this is what happens in amyloidosis. Okay, again here there is structural change, there is no immune deposit, there is no there is no immune deposit. You understand? This is what we see in the uh, non-immune related nephrotic syndrome. We can call it as only structural changes, right? But there is no immune mechanism is involved totally, right? So now we are going to have a disease. Okay, this is the basement membrane, and this is the podocyte. Okay, what is this? Endothelium. Okay, and we have here PLA2 receptor, phospholipase A2 receptor. So now the antibodies are produced in that person. Okay, this antibody complex is formed. Antibody complex is formed here. Understand? So what happens? They form a granular deposits. Okay, so immediately see there is no inflammation here. There is no inflammation here, but there is spikes is formed by the basement membrane. The basement membrane grows and it forms the spikes. So it is membranous glomerulopathy. Okay, and the spikes extensively increases and it forms a very thick basement membrane. Even you will not see the immune complexes. Even you will not see the immune complexes. Even in the immunofluorescence, it gets hide. So it is called membranous glomerulopathy. And remember, this membranous glomerulopathy can come in many diseases. Most importantly, you should remember hepatitis B. Hepatitis B. So don't forget the hepatitis B. Where you are writing? Hepatitis B infection. Understand? And malaria. Okay, malaria is also very important. Okay, so it's look like a, for example, the patient had malaria and you would have been recovered from malaria, and immediately you will have massive proteinuria and edema in the face. Okay, and if you check and they will take a renal biopsy and we will see membranous we see spikes all in the biopsy and we diagnose it as a membranous glomerulopathy, and we immediately we should ask whether the patient had malaria recently, whether the patient is known case of hepatitis B. If it is not known case of hepatitis B, check for hepatitis B. Okay, this is all the evaluation you have to do to know what could have caused him membranous glomerulopathy. Understand? So especially when you are dealing with adult, when you are dealing with elderly people, you should think of these things as well as about the cancer situation. Understand? So this is all about nephrotic syndrome. Okay, see now in renal biopsy I told you guys that once the biopsy comes, we make them into three parts. One is for light microscopy, one is for immunofluorescence, one is for electron microscopy. Understand? So now for example, this is the glomeruli in minimal change disease. You see any change in the light microscopy? No. In the in the immunofluorescence? No deposits, right? In the electron microscopy, what you see? Absence of podocyte food process. Absence of podocyte food process. Okay. Now you will see only in the electron microscopy. If it is a focal segmental glomerulosclerosis, what you will see in the light microscopy? Okay, you will be seeing some kind of focal lesion. In that focal lesion you will be seeing some kind of segmental sclerosis, okay. If it comes in the biopsy, well and good. If it is not coming in the biopsy, what you will diagnose? Minimal change disease. Understand? Okay, now let us discuss about membranous. Membranous you will be seeing spike. You will be seeing, consider this is a capillary. You will be seeing spike and thick basement membrane. Understand? Basement membrane may be thick and spikes will be there. Okay. In the immunofluorescence, what you will see? Yeah, you will be seeing granular deposits. Granular deposits in the which zone? Subepithelial zone. In the subepithelial zone. Okay, you are understand? Okay, clear? Okay, so it is a subepithelial zone. You guys both study together. Huh? Okay, so why you both guys are studying together? I mean, why you guys both joined? Both are twins or?
No, not twins.
So who is elder?
You.
Him. So why you waited for Asil? No, it happened in females. No, there are I know two Afghani female students. Elder girl waited for younger girl to finish. Both joined at the. So they are very close. Then?
No, he was another side.
Oh, okay. So then we joined here. Okay. So okay. So actually, the females, no sisters, they will be always close. But brothers, it's very difficult to be. Now, okay. Now coming to the, you all understand membranous glomerulopathy. Why there is immune deposit? Because there is antibody against the some part of the receptor, or some antigen would have been deposited in the subepithelial zone. Antibody is coming. That's what we see in hepatitis B patient, in malaria patient, or any other infectious patient. Okay, so this is about membranous glomerulopathy. So what you see in diabetic nephropathy? Remember, thickening happening in the basement, basement membrane, and the mesangium is also thickening, compress the capillary, and automatically they go for completely sclerosis. Okay, so they start with thickening of the basement membrane, thickening of the mesangium, then nodules, then complete sclerosis, then what we discussed, amyloid I discussed, taking example of tuberculosis. So in a chronic infectious process and chronic inflammation, liver becomes mad and they started producing three abnormal proteins. One is fibrinogen looks normal, but it should not be produced more, okay, because it is a clotting factor. So another one is serum amyloid A. Now coming to the serum amyloid A, it can deposit in the kidney. That creates amyloid nephropathy. And another type of amyloid is amyloid light chain. Okay, that is a light chain, abnormal light chain. Immunoglobulin has light chain, right? That is the abnormal light chain produced by the plasma cells. Plasma cell is a tumor. Abnormal light chains are produced. What are the things abnormal things produced? It has to be excreted out. So they all come to the kidney. They all deposit there. So in amyloid, immune deposit is seen or not?
No. Why there is no?
All are saying agreed, no? Okay, I am going to tell. In serum amyloid A, that is a protein secreted by the liver. Okay, that is not an immune protein. Okay, so if it that get deposit, you will not see immune reaction. But light chain is a part of immunoglobulin. Light chain is a part of immunoglobulin. If that gets deposit, so we can detect in immunofluorescence. You understand? So amyloid light chain. So these are the critical question I will ask in the exam. Okay. So amyloid light chain will produce immunofluorescence, but amyloid A will not produce immunofluorescence. Okay, because that is different amyloid. This is different amyloid. So the name itself is there. It's a light chain. That light chain comes from the immunoglobulin light chain. Okay. So this is all about nephrotic syndrome. So if you guys are so good active, then we can go for nephrotic. What about? Okay. Sure. Faisal. Okay, we'll conclude. Tomorrow we'll have one more session with us. Okay? Tomorrow evening. Because we'll finish nephritic this week. So we'll finish all the glomerular diseases. And tomorrow and day after tomorrow. Okay? So tomorrow I'll finish the nephritic.
Okay.
Day after tomorrow I'll conclude everything in a case scenario. Okay? So, you have any class? What class you have after 4 o'clock? Okay. So you guys are going for CNS class, I mean Dr. Osama class.
No. Other physiology.
In physiology you are taking from Jamia?
Yes, I'm
Huh?
I have another class outside. We study physiology outside.
So from whom you are studying? Because some of the students are asking me physiology.
Dr. Hussain is from kindergarten.
He takes where he takes? You guys put that information all in the Facebook, so students can know, no?
Yes,
Because 6th-year student, one of the students came 2 days back, and she was asking me about. She's preparing for USMLE. She was asking me about they know anatomy he takes, and physiology, biochemistry, and all she was asking me. I told I don't have any idea. Biochemistry previously somebody used to take in Ignition in the hospital. I think I think 2-3 years. She only told. So anyway, fair.